So with that, let me introduce, if I can, the panel that will follow. And I'll do it very briefly in the interest of time. First of all, my friend and colleague, Suzanne Delbanco. Suzanne is the head of Catalyst for Payment Reform. And following Suzanne, we'll have Jeff Joyce from USC. And then following him, I see Jamie's just arrived, Jamie Robertson from Berkeley, all well-known people who can lay out some ideas for us to think about and react to the rest of the day. So with that, thank you. And Suzanne?
Thank you. Suzanne Delbanco, Executive Director of Catalyst for Payment Reform, and I was just making a joke about how I spent a lot of time in high school doing competitive debate, flying around the country trying to make as many arguments in as short a time as possible, and when I have a timer in front of me like this, it kind of brings me back to that moment. But I will try to speak slowly enough that you can actually hear my points, because I really want to leave you with some thoughts about how Catalyst for Payment Reform sees the world and the ideas we have about how we can make healthcare more affordable, higher quality, and higher value over time. So let me start by introducing you to our organization, because some of you may not be familiar with it. And then I'll talk about the strategies I want to share with you. So the most important thing you have to know about Catalyst for Payment Reform is that CalPERS is a member. I said this when we were meeting earlier, and I mean it because it's such an endorsement that they think it's worth their time to spend some time with us. And really what we try to do is provide thought leadership to and coordination among employers and other big healthcare purchasers who want to get better value for their healthcare spending. And as our name implies, Catalyst for Payment Reform, or if you can't remember the name because it gets confusing to people, just remember that the healthcare system needs CPR. We work to provide thought leadership, coordination among these purchasers because they believe that payment reform is an underutilized lever in trying to drive value in the healthcare system, and that there are other strategies that if we employed in a broader manner at scale could also make a big difference in making healthcare more affordable and higher quality. So while our name, Catalyst for Payment Reform, suggests payment reform is all we're about, as we work to try to find ways to improve value, we can't just stick to that topic. We find ourselves veering into other categories, and those are the solutions I'll be talking to you about today. If you look at our membership, though, I just want to make a comment that we have many large private employers. We have a growing number of state employee, retiree, and Medicaid agencies, and we also have the three big benefit consulting firms at our table. So just to set the stage, I mean, John just covered it really well. I don't think I need to go into it too much more, but why are healthcare costs continuing to rise? The one thing that I remain pretty obsessed with is the fact that much of what's driving our healthcare cost growth today is price. This is not the underlying demographics of the nation. It's not the new technology. It's not the specialty drugs everyone wants to point to. It's price. And this is something that gets negotiated between parties. And as I'll share with you as I go through the solutions, we have a marketplace right now that is not acting as we would like it to. It's not as competitive as it needs to be for price to represent any semblance of value. Price and quality are completely disconnected. But price is this big driver. Also, the way we had historically paid healthcare providers was inherently inflationary. And while everyone loves to talk about how we're now moving away from fee-for-service as we implement payment reforms, in fact, the fee-for-service system is very alive and well, and I'll talk about that a little bit more. We're trying to put Band-Aids on top of it, but we're still not necessarily addressing the underlying pay for volume type of approach. And then we've also, as you all know well, had a system in which, lucky for us as consumers, for many years we were very insulated from the costs of healthcare. And so we weren't well trained to have to think about what healthcare costs. And so that is a driver of healthcare cost growth as well. So one by one, I'm going to try to tackle 5 solutions in the remaining 6 minutes that I have. Payment reform. This is about changing how we pay doctors and hospitals to try to create incentives and create an environment that's conducive to higher quality care and more affordable care. We have seen a huge flurry of activity in this direction since CPR was founded in 2010. CPR is not solely responsible for the catalyst that we brought to the marketplace, but we helped drive and put pressure on health insurers to change the way that they were paying doctors and hospitals. We have seen since 2010, when only 1% to 3% of payments were tied to performance, we're now at about 50%. But all of these alternative payment models, as they are called, with very few exceptions, and California is an exception for how much capitation there is, are built upon a fee-for-service chassis, where on top of that we put targets for healthcare spending or for quality or other things, and sort of add some incentives on top of the perverse ones. In California, with its history of capitation, it's an exception, but if you look across the nation, it's very different. So while these new models of payment are here to help support new models of care delivery, accountable care organizations, patient-centered medical homes, we still need to go back to the fundamental underlay, the fee-for-service system and the fee schedule, and look at it. We pay too much for some things that happen too often. We pay too little for things that should happen more often, and there are some things we don't pay for at all that we should pay for. And as much as it sort of sounds retro to say we got a fixed fee for service, it's an important thing that we need to look at to enhance value. As an example, if you pay less for cesarean deliveries than you do today and more for vaginal deliveries, you can be pretty sure the mix of services is going to change, overnight. And so we need to look at the fee schedule. We also need to evaluate which of these payment reforms work. It's really easy in one anecdote after another to say that payment reform is very successful, but we have an incredibly adaptive system where you save money over here, suddenly there's more volume happening over here, or a higher price for something over here, or different incentives happening in a different part of the building. We also need to think about how to make smart pairings between payment methods and the incentives that consumers experience so that the provider and the patient are aligned in what they're seeking. So moving on to the next topic. This doesn't seem to be working. Let's talk about benefit design. So I talked about the importance of aligning the incentive for providers with those that consumers experience. Thank you. And benefit design is really about what access to services patients can have who have a certain insurance product, how much they have to pay in terms of their portion of it, how much authority figure has to weigh in on whether or not they can gain access to a service at all, and other requirements that affect how and when and how much a consumer has to pay around using services. Most of the experimentation today is happening around how much cost sharing consumers should have when they seek different services. And CalPERS is famous for pioneering with reference pricing for services other than pharmacy. There's a lot of discussion today about value-based insurance design, waiving the cost sharing for certain services that patients don't gain access to often enough. And we've got all kinds of different health plans out there, and some of which mean at the point of service, there's different amounts that the consumer pays when they seek care from one provider versus another. All this is potentially promising, but it's also very confusing for consumers, which is why I will then mention provider network design. Many employers that we work with are starting to realize that getting into the fine details of a service costing more here and less there is confusing. And so one of the things that I think we're going to see a lot of growth in are more limited or narrow networks where the decision is made at the point of open enrollment, where a patient says, if I want to pay less for care throughout the year, I'm willing to make some sacrifice of choice for lower premiums and lower cost sharing. And we're seeing that consumers understand this model more readily. In California, of course, we're all used to it with HMOs that are present here, but in other parts of the country, this is new stuff. And of course, the public exchanges, covered California included, have helped really make this option more visible to people and more aware of the potential savings that can be incurred. So consumers ultimately benefit from potentially lower premiums, more efficient care, vetted providers who are in the network because they meet certain criteria, although in research we've done with health plans, we know that the number one criterion is just how much that provider charges that health plan, not so much on the quality, so there's some work to be done there. But the trade-off is one that consumers are increasingly willing to make, and providers, if they're in the network, they like them because they might get more patient volume. So in addition to payment reform, benefit design, provider network design, many of these things require greater transparency into what's happening in the healthcare system. Again, when CalPERS worked on reference pricing or Safeway worked on reference pricing, they realized they needed to have information for people to be able to identify the providers that would meet the reference price, that were the ones that they recommended based on quality vetting for hip and knee replacements and the price tag that the providers were willing to charge. But transparency matters at many, many levels. And I would say that we need more transparency in healthcare generally, especially for those who use and pay for healthcare. One of the things we're working on at CPR as an example is a standard template report that we want health plans to use in sharing the results of their ACO arrangements with their employer customers. Because each health plan does it differently. Each plan tells us about the 3 things that are working great, and they're totally different measures than the next health plan, and we don't get the full picture. So that's one level of transparency. There's the individual consumer who needs transparency, and there's transparency into conflicts of interest, into relationships. If you go to Massachusetts and you're a policy wonk like I am, you'll see that the state has incredible transparency into the relationships among providers and payers, and they've been able to use that to think about how to structure the market in a more competitive way. The last thing I will say is that market dynamics matter. And in California, we have wildly different markets. In San Francisco, we pay much more for healthcare services than people do who've traveled up here from Los Angeles. Now, why is that? Well, again, I said we set out to do payment reform. It's like a little drop in the bucket in terms of enhancing value compared to the tsunami that provider consolidation is having on the overall value of healthcare because prices keep going up. And the evidence just keeps mounting. As there's consolidation among providers, prices get higher, and sadly, quality does not improve. In fact, there is some evidence that it gets worse. So what can employers and other healthcare purchasers do about it? Some of the benefit designs and provider network designs I mentioned, more transparency, encouraging patients to use alternative sites of care, et cetera. I think I did it maybe 5 seconds over. So thank you for your attention.
Thank you, Suzanne. Let me just ask a couple follow-up questions. Here we are in California, probably the most advanced state in terms of managed care and organized health delivery. But yet all these problems that you identified are seems like just as evident here. So are we seeing any evidence that this makes a difference, the structure of high penetration managed care?
Well, I think there are other people in the audience who know the data cold better than I do, but certainly from a population health perspective, I think California does do better than a lot of other places. There are, certainly you look at Covered California, you look at some of the options that have been in the marketplace pioneered here, and they have helped contain costs. In particular, I'm thinking about narrow network options. But every actor in the healthcare system is beholden to the same kind of incentives we all are. And you hear about systems that are supposed to be incredibly efficient, but yet their prices are awfully close to one that's not a staff model HMO. So why is it that happens?
Yeah. So for every one of the drivers of costs that you identified, you did mention some remedies except for consolidation. That seems like the toughest one. Do you have any ideas for what we can do about consolidation of market power?
Oh, there's lots of resources we have on this. What we have been working on at CPR is both to enhance transparency so that we can at least understand how much payment variation there is, which is a lot. We can understand its lack of relationship to quality, and we've been trying to support employers and other purchasers to use some of the ideas that I shared here that can stimulate competition, whether it's using telehealth to control utilization of an overpriced healthcare system, or how to use a narrow network, or centers of excellence where you ship people out of state, or at least threaten to, unless the providers at home come down in price. So we don't have time for all the ideas, but those are the kinds of things we try to support purchasers with.
Thank you so much, Suzanne.